So I'm Professor Con Tam. I am a haematologist that work at Peter MacCallum and St Vincent's Hospital in Melbourne, and I have a special interest in B-cell non-Hodgkin's lymphoma, which includes mantle cell lymphoma. So I think many patients obviously will feel disappointed that they've got a return of the lymphoma after having had the first-line treatment for mantle cell lymphoma, which would sometimes include chemotherapy and other times include chemotherapy and a stem cell transplant. We used to think for a while that maybe patients who undergo the very intensive stem cell transplant are potentially cured from the mantle cell lymphoma, but we now realize that we have done a very good job, but we have not cured most of our patients, although the remissions can last many years, 7, 8, 9, 10 years or more. So what happens in relapse? When a patient relapses from mantle cell lymphoma, we know that the lymphoma cells have experienced the chemotherapy that we've had in the past and is therefore likely to be resistant to the chemotherapy drugs that we've used before. The other principle is that most patients who are resistant to one type of chemotherapy drugs tend to be resistant to other types as well, albeit to a lesser extent. So in the days before, we have what we call targeted therapies, which is drugs that treat the lymphoma in ways other than chemotherapy. Our choice was to rotate around the unrelated types of chemotherapy, but the responses and the duration of responses are not as good. In this day and age, most patients will probably go into a targeted therapy, and in particular a class of drugs called BTK inhibitors, of which the most commonly prescribed drug is ibrutinib. This is a medication that disables the cell's ability to derive nourishment from the body. So in a way, you're starving the cell of nutrition. It is a drug that is taken as a tablet. It does have very few side effects compared with chemotherapy, and it is effective in the majority of patients. So in about 75 to 75% patients will respond to ibrutinib, which is a tablet. However, we do know that the responses do not last forever. We know that the tablet is not curative, and that we do need to develop treatment to improve upon ibrutinib. What we also know is that patients who got ibrutinib as the first treatment after having only one prior therapy, i.e. chemotherapy, and then going straight into ibrutinib at relapse, they do better than patients who, let's say, undergo many different rounds of chemotherapy before ultimately going on to ibrutinib. So the preference is to use a drug like ibrutinib early, and in this day and age, we tend to use it, as I said, after people have relapsed from the first line of therapy.